So hey guys, welcome everyone to the Farre Series, and today we will be covering the gastroenterology topics. Sorry for a slight delay. I was also live on another YouTube video for the FMGE students. Okay, so now what are we going to discuss today? We will try to cover the important questions from gastro and some important questions from hepatology. And without wasting your time, let me start with the first question. The first question from gastro is important, usually asked in many university papers for 5 marks, sometimes 10 marks, or sometimes this combined with diarrhea, it can be asked for 10 marks. Right. Now, how will I write if it is for 5 marks or 10 marks? Okay, so the question goes like this: define irritable bowel syndrome, for which we will give 1 mark. Elaborate on the diagnosis, that will get 2 marks. The classification will get 2 marks, and the management will get 3 marks. So that roughly transforms into 7 or 8 mark question. So we can definitely squeeze in for 5 marks. When it is added with other questions, it will become a 10 mark question. Okay. Now what should I write? Shivu, hi, welcome. I'm good. What should I write as the definition of irritable bowel syndrome? 2 points I want you to include. Number one, first and the most important thing is that irritable bowel syndrome is not an organic disease, it is a functional disorder. So we have to mention that it is a functional bowel disorder. That is the first important statement. Presenting, that is the second part. Presenting as recurrent abdominal pain, diarrhea, or constipation. Recurrent abdominal pain, diarrhea, or constipation. That completes our definition of irritable bowel syndrome. The important wording here is that it's a functional bowel disorder. Now, what is a functional bowel disorder? A disorder which does not have a major anatomical or structural and biochemical abnormality underlying the disease. I said major. Like, okay, there's no deficiency of lactase. Right? It's not because lactose intolerance that the patient is having diarrhea or abdominal pain or constipation. It's not because of the inflammatory bowel disease. There is no inflammation. So there are no structural or anatomical or biochemical major abnormalities responsible for a disease. Such disease we call them as functional disorders, and this is one functional bowel disorder. So what symptoms these patients present with? Usually they present with abdominal pain, which is usually recurrent. Second thing, they can present with, in addition to the abdominal pain, they can have constipation or they can have diarrhea. And usually the constipation and diarrhea, collectively I can say altered stool frequency. Stool frequency is either increased or decreased, or altered stool pattern, or you can say stool form, that it is not solid anymore or it is too liquid for the consistency. So altered stool form or frequency and abdominal pain. These are the clinical features that these patients present with. Now, when someone presents with these features, it may be an organic disease, right? How would I know whether he is having inflammatory bowel disease or a diverticular disease, right? Or a ileocecal tuberculosis? Organic diseases are a possibility, right? So how will I come to the diagnosis? So we have to remember that it is a diagnosis of exclusion. It is a diagnosis of exclusion. It's a diagnosis of exclusion. So what do I mean by that? We have to rule out the major causes for these symptoms. If patient is having chronic diarrhea or chronic constipation or recurrent abdominal pain, I have to investigate, right, to rule out the other causes. But there is a criteria laid out which you should write in the exam paper. The criteria is called as Rome 4 criteria. It's called as Rome 4 criteria. So what this Rome 4 criteria says? The Rome 4 criteria says to make a diagnosis of irritable bowel syndrome, first thing you need is recurrent abdominal pain. Recurrent abdominal pain for more than or equal to 1 day per week for at least 3 months. For at least 3 months. And then I have to mention one more point here. The onset of symptoms 6 months before the diagnosis. Symptoms at least 6 months before the diagnosis. I will brief you what does that mean so that you can remember it. 6 months before the diagnosis. So now what do I mean by this? Patient should have had experienced at least one episode of abdominal pain per week. Means हर हफ्ते एक ना एक बार abdominal pain होना चाहिए in the last 3 months, right? That is the average. Like in last 3 months, at least 12 episodes of abdominal pain, that too distributed as one episode per week or more than that for the 3 months. And these symptoms that we're talking about, that is abdominal pain, should have started 6 months back. In last 3 months, on an average, it is one per week, 1 day per week or more. And symptoms have started 6 months back. I'm not looking at the history of the first 6 months, the first 3 months. Right now, I'm only looking at last 3 months. In last 3 months, it should be at least 1 day per week. There should be abdominal pain, and the symptoms should have started 6 months ago. Okay. Then there is a second criteria that we need to satisfy. What is it? The symptoms or the abdominal pain should be related to defecation. The above symptom should be related to defecation. Or in more simple words, I would state that I will list 3 features. At least 2 of them should be present, right? At least 2 of the 3 listed below. So what are those? First one is change in stool frequency. Means abdominal pain is there. Along with that, patient's stool frequency has either increased or decreased. Like earlier, he used to go to the toilet every day. Now he is going once in 3 days or once in 4 days. Or he used to go once a day. Now he is going 4 or 5 times. Right? Change in stool frequency. Second is change in stool form. Change in stool form. So earlier the stool used to be normal in consistency. Now it is way more harder or way more loose. Change in stool consistency. Third one is symptoms related to defecation. Symptoms related to defecation. Now, what do I mean by that? Whatever symptoms we described now, the abdominal pain and all, they're related to defecation in the sense usually after passing the stool, the abdominal pain comes. That's a usual story. Most of the IBS patients come to us and say, sir, after passing the stool, the abdominal pain comes. Right? That is the third point. Then we have one more important point here. Absence of warning or red flag symptoms. Warning or red flag symptoms. Now, what do I mean by that? These are the symptoms which are suggestive of alternate diagnosis. Let us say that I have got a patient with, we will write just few examples. Okay. Age of the person more than 50 years or blood in stool or weight loss or fever. What do they suggest? If age is more than 50 years, there's every possibility that patient may be having a colorectal cancer. So it's a warning sign, right? So it should not be there. I have to rule this out before I make a diagnosis of irritable bowel syndrome. If there is blood in stool, it could be MBBS, it could be ulcerative colitis, right? Or it could be mesenteric ischemia. If patient is having weight loss, it may be pointing towards ileocecal tuberculosis or the colorectal cancer. If he is having fever, it may be pointing towards amoebiasis, enteric fever. It may be pointing towards the colorectal cancer. It may be pointing towards the Crohn's disease, which can present with fever. So these are all considered as warning signs or red flag signs. So they should be absent before you make a diagnosis of irritable bowel syndrome. So this criteria we call it as ROM 4. 3 things are there. First, recurrent abdominal pain. At least 1 day per week in the last 3 months on an average, and the symptoms have started 6 months ago. Second is, out of the 3 features listed below, at least 2 should be there. Either there should be change in stool frequency, stool form, or the symptoms should get better on defecation. Last one, absence of warning or red flag signs. Now, if you say, sir, can I make a diagnosis of irritable bowel syndrome in presence of red flag signs? Yes, we can, by ruling out what is in our mind as a differential diagnosis. Like if I get a person more than 50 years presenting with all the features that we just described, then I will definitely do a colonoscopy to rule out a colorectal cancer. Once the colonoscopy is normal, I can make a diagnosis of irritable bowel syndrome. Okay. If a patient has blood in stool, it may be MBBS, right? I will treat it. After that, he still may be having irritable bowel syndrome. But after making sure that the cause for blood in stool is addressed, then only I can make a diagnosis of irritable bowel syndrome, right? If someone presents with above symptoms and fever, he may be running a viral fever, cold, urinary tract infection. Once the cause for fever is addressed and still these symptoms persist, then I will call it as irritable bowel syndrome. Now, the irritable bowel syndrome patients will be classified into four major categories. And the classification is important for us to write the management, because as we learned here, it is a functional bowel disorder. So will I be able to treat the root cause? No, it's a functional cause, right? There is no structural abnormality for me to surgery and correct it. There are no biochemical abnormalities for me to make some pharmacological treatments. So it is mostly about symptom management, right? It's a functional disorder. It is about symptom management, but symptoms, we have to know whether it is the constipation side or whether it is leaning towards diarrhea side. So that's why the patients with irritable bowel syndrome will be classified into constipation predominant. We will call it as IBS-C, or diarrhea predominant. We will call it as IBS-D. Or patients may be alternating between diarrhea and constipation, right? We will call them as IBS mixed. And then we can also have patients who will not be, we will not be able to classify them into the diarrhea predominant or constipation predominant or mixed. We can call them as unclassifiable or pain predominant or pain predominant. So we'll have the first class. Okay, now how will I classify it, right? It will be based on the stool pattern. Based on stool pattern. Stool pattern. Shiv, I have not seen any question for you. Okay, we will be coming to the medications as well. Okay, so based on stool pattern. Now, how will I get to know the stool pattern? Patient may say, sir, my stool is loose, my stool is hard, but can I just take the patient's words here? No, because what constitutes as hard stool or loose stool has to be objectified. So how will I objectify it? We will be using the tool for stool pattern assessment. It will be called as Bristol stool chart. Bristol stool chart. So Bristol stool chart has the gross appearance of the stool. There will be images, 7 images of different appearance of the stool. Okay. And then patient will be asked in 1 week, how many days the stool looks like the image 1, how many days the stool looks like the image 2, how many days the stool looks like image 3, 4, how many days it looks like 5, 6 or 7. Okay, so based on that, we will classify them into IBS-C, which is constipation predominant. It is constipation predominant. Constipation predominant. Now, what do I mean by that? Here, the patients will have more than or equal to 25% of stools constipated, belong to constipation category. So what is that? The Bristol type 1 and 2. Bristol type 1 and 2. And then we will have IBS diarrhea predominant. Shivu, no. The celiac disease cannot be differentiated from the irritable bowel syndrome just on the history. It has to be investigated. If you are suspecting celiac disease, investigation should be considered before you come to the diagnosis of irritable bowel syndrome. Okay, so then IBS-D. So if the patient is, it is diarrhea predominant. So if the patient has more than 25% of the stools, more than or equal to 25% of stools are liquid in consistency, which is Bristol chart higher than Bristol chart higher than 5, means 5, 6, 7. And if they do not meet these criteria, we will call them as unclassifiable or pain predominant. And if they meet both the criteria, right? We have 7 days. Let us say 2 days patient had stools type 1 and type 2. 2 days here patient stools 6 or 7. Then he is meeting both the criteria. Or let us say 3 days his stools were like this, 3 days his stools were like this out of 7 days. So he is meeting this criteria also, he is meeting this criteria also. So then we will call them as IBS-M, which is mixed. Mixed. Meeting both above criteria. Meeting both above criteria. Then we will have IBS, unclassifiable or pain predominant. Why are we calling it as unclassifiable? Because patient does not satisfy any of these criteria. Like one day he has constipation predominant, the other day he has diarrhea. The remaining days his stool is neither constipated nor diarrhea. So he is not accumulating 75% of stools to be constipated. His not his 75% of his stools are not diarrhea side. So we will not be able to classify him into diarrhea predominant or constipation predominant. So we can call him as either unclassifiable, or pain is anyway an essential symptom for diagnosis. Right? What have we learned here? The pain is required for diagnosis. Without pain, today we cannot make a diagnosis of irritable bowel syndrome. So we can call it as pain predominant. Pain predominant. Okay. So now coming to the management. So we will be discussing the celiac disease also. So where you will get an idea how the evaluation of celiac disease happens. So how will I manage? It's a functional disorder, right? There is no anatomical problem. So we'll primarily address the symptoms. How can I address the symptoms? So there are a few things. One, dietary changes and the pharmacotherapy. What is the dietary change that we need to make? So we have to give them a diet which is called as low FODMAP diet. FODMAP diet. So what does that mean? FODMAP refers to fermentable, means the substance which can be fermented by bacteria in our intestine. Fermentable oligo, di, monosaccharides and polyols. What are polyols? Nowadays you eat a lot of artificial sweeteners in the food, right? Like for example, there is this maltitol, erythritol. These are all fermented alcohol, means sugars, right? Sugars converted to alcohol. We will call them as polyols. So fermentable oligosaccharides, disaccharides, monosaccharides and polyols. They should be less in the diet. Why? Because the patient takes it, they go into the colon, the bacteria ferment them. With the fermentation process, they liberate a lot of gases that contributes to pain as well as diarrhea. So patient should be on low FODMAP diet. Now coming to the pharmacotherapy, of course it is going to depend on the type. So if it is constipation, what will be my first line treatment? And those who are not responding, what will be my second line treatment? If it is IBS diarrhea predominant, what can be my treatment? And if it is IBS pain predominant, what can be my treatment? So if it is a constipation predominant, the first line treatment will be primarily giving them high fiber diet, right? Give them good amount of diet in the fiber in the diet. It can be in the form of fruits, vegetables and green leafy vegetables, or it can be supplementation like in the form of psyllium husk, right? What you call as isabgol in the local language. Second, we can also consider giving them lactulose. Yeah, lactulose. Okay. And if it is not responding to high fiber diet and lactulose, right? As a second line agent, what I can use? As second line agents, what we can use? Okay, so one thing we can consider giving them is prokinetics. Okay. And if I have a diarrhea predominant patient, what can I use as the first line? So for a diarrhea predominant patient, the go-to drug whenever someone gets loose stools, what pharmacist gives, whenever you go and ask them like, sir, I have loose stool, give a medication, they give you loperamide. The usual dose is 2 milligrams. But if this is not helping, what else I can use as a second line agent if loperamide is not helping? So as a second line agent, we can consider a long list of drugs are there. One of them is cholestyramine, which is a bile acid sequestrant, cholestyramine. Okay. Then we can consider using rifaximin, which is a luminal antibiotic. Now, what do I mean by luminal antibiotic? It is an antibiotic which is not absorbed systemically. So when I take it, it won't reach my blood. Very minimal, negligible absorption. So whatever action it does only in the intestines and gets passed in the stool. So if there are abnormal growth of bacteria which is contributing to fermentation of the dietary carbohydrates and creating the symptoms, it will kind of take care. Then the third thing we can use is clonidine, which is an alpha blocker. Clonidine. Okay. Now, apart from the prokinetics, we also have some more drugs which are relatively new for the management of constipation, predominant irritable bowel syndrome. So that includes drugs like tegaserod, and then we have prucalopride, and then we have linaclotide. Okay. And if it is pain predominant as first line agent, we can use antispasmodics like dicyclomine. Antispasmodics, example being dicyclomine. And as a second line agent, studies have shown that antidepressants, mainly the tricyclics, can help. Tricyclic antidepressants are also useful for treatment of the diarrhea predominant irritable bowel syndrome, but this is the standard approach that we follow, right? So what should we do once we make a diagnosis? We put all of them on low FODMAP diet, and then we will start with the first line medications. If patient is not happy with the first line medication, we have a choice of second line medications. No, we don't have to change the doses for these patients as such. 2 milligrams or 4 milligrams would be more than adequate for most of the patients. Okay. So that's about SSRIs are also useful. Particularly more useful if we want to use it for pain predominant patients, as well as they're useful in patients with the IBS constipation. Okay. Next, the next question is about malabsorption. It's a vague question. Most of the universities have a vague question on malabsorption. So question will go like this: explain the clinical features of malabsorption syndromes. Discuss the evaluation of a patient with malabsorption. Okay. So if it is 5 marks, you can just basically write about some causes, some symptoms of malabsorption, and then the diagnostic evaluation. But if it is 10 marks, the diagnostic evaluation has to be more detailed, like what investigations you do for carbohydrate malabsorption, what investigations you do for fat, what investigations you do for the protein malabsorption. So the clinical features of malabsorption, let us label it for 4 marks. The evaluation, let us label it for 6 marks. Okay. So now let us begin with the definition. What is malabsorption? So malabsorption refers to impaired absorption of micro or macronutrients despite adequate dietary intake. Patient is taking less, it's not malabsorption, it is malnutrition, right? So malabsorption refers to impaired absorption of macro or micronutrients despite adequate dietary intake. So even if the patient is eating sufficient, still it is not reaching his circulation, then we will call it as malabsorption. The patient is not eating sufficient, and that is why he is having deficiency of the nutrients. It is malnutrition. Now, how many types of malabsorption we have? We have primary malabsorption syndromes, secondary malabsorption syndrome, and inherited or congenital malabsorption syndrome. Now, what comes under primary malabsorption syndromes? 1. Celiac disease. So, in celiac disease, the disease is affecting your duodenum and some extended part of the small intestine, and because a reasonable number of nutrients get absorbed there, it is causing malabsorption apart from some flatulence related symptoms. Okay. Then second, tropical sprue, then lactase enzyme deficiency, or you can also write it as disaccharide deficiency. So these patients' main clinical outcomes are related to malabsorption, right? But then we can also have Shiv, we will be discussing the questions on IBD also. We will go there and discuss about it. Okay. Now, the secondary malabsorptions are where the primary pathology is causing some damage to the intestine, and as one of the outcome of it, we also have malabsorption. So, main diagnosis is not malabsorption. Main diagnosis is something else. Malabsorption is one of the feature of that main diagnosis. Examples include small intestinal bacterial overgrowth or pancreatic insufficiency, as in chronic pancreatitis, right? A lot of patients with chronic pancreatitis. Now, you might have heard that there is something called as chronic fibrocalculus pancreatitis, which is very common in Kerala and some other southern states, the states where there is consumption of tapioca or the cassava. So there the whole pancreas become fibrosed, calcified, starting with the inflammation, eventually fibrosed and calcified. All the ducts become occluded with the stones. Now that pancreas will not be able to secrete the pancreatic protease enzymes and the lipase enzymes. So you will not be able to digest proteins and lipase well. Right? So the end result is you have malabsorption as one of the symptoms. Most of these patients come to hospital with the chronic fibrocalculus pancreatitis is with abdominal pain. And the main diagnosis is going to be chronic pancreatitis. But malabsorption is also one of the symptom there. Okay. And then sometimes it can be post-surgical. Means for surgery, sometimes you have to resect the stomach or resect the colon or resect the ileum. In such cases, whatever nutrients that get absorbed in that particular segment of the bowel will not be absorbed, and we will have the deficiency of those substances. Like just to give you an example, the iron absorption largely happens in the duodenum. So if for some reason I have to resect the duodenum, there will not be iron absorption happening. B12 absorption happens in the terminal ileum. So if I resect the terminal ileum, B12 absorption doesn't happen, right? So post-surgical, mainly when the segment of the bowel is resected, be it stomach. If stomach is resected, there is no production of intrinsic factor of Castle. So then B12 will not be absorbed. Same if I resect the terminal ileum, B12 will not be absorbed. So it can also be post-surgical. And then we have certain congenital causes. One of them is A beta lipoproteinemia, which in itself is a question in biochemistry. And then cystic fibrosis. Cystic fibrosis causes malabsorption primarily because cystic fibrosis causes pancreatitis, and thus it results in pancreatic insufficiency. And then we will have the deficiency of lipase and proteolytic enzymes, and we can end up with malabsorption. Okay, so these are the three causes: primary, secondary, and congenital. Okay, now the question is, what clinical features a patient with malabsorption syndrome present? For pleasing the examiners, let us divide the features into general and nutrient specific, right? That makes it more easier for us to channelize our thoughts. What are the general symptoms that a patient with malabsorption present? One of the common symptoms of malabsorption, and in fact, as a doctor, I start suspecting malabsorption is when patient present with chronic diarrhea. And when I say chronic, means more than 4 weeks of loose stools. Because whatever nutrients that are not absorbed are getting lost in the stool, many of them end up developing diarrhea. Second, if there is malabsorption syndrome, patients can have weight loss, or if it is a child, it can be failure to thrive. Failure to thrive. If it is micronutrient malabsorption, patients can have anemia, right? Patients can also have abdominal pain, because if you are not absorbing, just to give you an example, if you're not able to absorb carbohydrates, then these carbohydrates will travel through your stool and they will reach the large intestine, that is your colon. And once it reaches the colon, there are a lot of bacteria sitting there to utilize this. So they will start digesting it. But how do they digest? They ferment it. When they ferment, there will be liberation of carbon dioxide gas. And that gas gives you flatulence and abdominal pain, right? That's why in the irritable bowel syndrome patients, we are asking them to avoid the fermentable foods in the diet. That is the FODMAP diet we were recommending, right? So these are general symptoms. What I want you to highlight is chronic diarrhea, because whatever cases of malabsorption that get diagnosed, majority of them present to hospital with the chronic diarrhea as the complaint, right? But you can also write nutrient specific, right? If there is, let us say, carbohydrate malabsorption, right? If there is carbohydrate malabsorption, what symptom would I expect the patient to present with? If there is carbohydrate malabsorption, patients will present with flatulence because the carbohydrates will be now fermented by bacteria. Patients can have weight loss because majority of our calories come from carbohydrates, right? So if it is protein malabsorption, patients can have, because there will be hypoalbuminemia, patient can have edema and skin changes, right? We will call it as dermatosis. Dermatosis. Okay, if it is, let us say, iron malabsorption, what symptom patient will present with? Patient will present with microcytic hypochromic anemia. If it is fat malabsorption, right? If it is fat malabsorption, patient will present with steatorrhea. If it is, let us say, B12 or folic acid malabsorption, patient will present with macrocytic hypochromic anemia. So we can also try to be a little descriptive of the nutrients, right? If you want, you can also write the 3Ds of niacin malabsorption or the pellagra. You can elaborate on it. But try to have these headings: the general symptoms of malabsorption syndromes and nutrient-specific symptoms of malabsorption syndromes. It is more pleasing for the examiner to see that, okay, the student knows something, and whatever marks he wants to give for clinical features, he will give you. Okay. Now, once I have a patient with malabsorption syndrome, I have a clinical suspicion because patient is losing weight, he's having diarrhea. I can see that the skin changes are there, hair changes are there. He also mentioned that his stool sticks to the commode, so that means he has steatorrhea. Now I have to evaluate, and I want to understand what all nutrients are not being absorbed. Is it carbs? Is it protein? Is it fat? Or is it micronutrients? If it is micronutrients, I have to do the blood levels, right? I will check for the serum iron profile, I will check serum B12 levels, I will check serum vitamin D level. I can check all those micronutrients, blood levels. But for macronutrients, we need to do specific tests. So what is the test that we do for the carbohydrate malabsorption? So for carbohydrate malabsorption, we do a test called as oral D-xylose test. So what do we do in this test? We ask the patient to consume D-xylose. What is D-xylose? It is a simple sugar, just like your glucose, right? It's a pentasaccharide. It's a simple sugar like glucose. We'll ask him to consume it. Okay. And after 5 hours, we will check how much of D-xylose get excreted in urine. Okay. Now, why are we using D-xylose? I can also give glucose and check after 5 hours how much of glucose is excreted in urine. See, remember, if there is malabsorption, I will not be able to absorb much. So if nothing is going to my blood, I will not be able to excrete much in urine. How do I excrete? First, I have to take, absorb it. Then that absorbed substance goes to the kidney through blood circulation, and then kidney excretes it, right? But why I can't use glucose? For 2 reasons. One, kidneys don't excrete glucose until and unless it is at very high blood level, right? Only diabetics will have glucosuria. Normal person won't. Whatever glucose that gets filtered in the kidney, SGLT2 will make sure that it gets absorbed. Second, if I take a fixed quantity of glucose, my body will also utilize, right? If I have just completed an exercise, whatever glucose I take, my muscles will take it up. Nothing will go to kidney for excretion at all, right? That's why glucose is not a right choice. D-xylose is. D-xylose has excellent absorption at intestine, but zero utilization by the tissues. Our tissues cannot use D-xylose for calories, for generating ATPs. So whatever D-xylose I have taken in, kidney will eliminate it. And if kidneys excrete more than 4.5 grams within 5 hours, that means good amount of D-xylose has been absorbed. There is no carbohydrate malabsorption. There is no carb malabsorption. But if my kidneys are excreting less than 4.5 grams, what does that mean? I did not absorb much. That's why my kidneys are not excreting much. So if the excretion is less than 4.5 grams, it is suggestive of carbohydrate malabsorption. Suggestive of carbohydrate malabsorption. Okay. Similarly, what test I can do for the protein malabsorption? The test I can do for the protein malabsorption is I can check the stool elastase and chymotrypsin levels for protein malabsorption. Of course, we will have the clinical features. So one more thing that we can consider here is the serum albumin levels. Serum albumin levels, but we have to always keep in mind that there can be a protein losing nephropathy, like your nephrotic syndrome or nephritic syndrome, where small amount of protein loss may be happening, and even liver disorders where albumin production may be less. So that's why it's not a most reliable marker, but it can be taken as an initial screening tool. If albumin is low, you can think that it may be a case of protein malabsorption. But most importantly, for establishing the diagnosis of protein malabsorption, we have to estimate the stool elastase or chymotrypsin. Now, what about fat malabsorption? Fat malabsorption, in most cases, it is clinically evident. Patients will come and say that I have steatoria. What does that mean? I have fatty stool which sticks to commode and it is very difficult to flush. In such cases, I have to estimate the fecal fat. Now, how will I estimate? There are two methods, a quantitative method and a qualitative method. Qualitative method is more simpler. All we have to do is ask the patient to provide one stool sample, right? And we will stain that stool sample with the stain which can stain the fat. Either it can be oil red O or Sudan 3. Sudan 3 is most commonly used. And once I have stained it, I will examine under the microscope. So if under the microscope, if I see more than or equal to 6 fat globules per high power field of the microscope, that means patient is not absorbing fat well. That's why it is getting eliminated in the stool, right? It is a simple investigation, but there are a lot of pitfalls with this approach because it is not taking into account how much fat the patient is taking, because there is a limit to the fat digestion by our pancreatic enzymes. So if I take too much fat, even a normal person can excrete good amount of fat in the stool, and in such cases this can be falsely positive. Most of us might have experienced when we take too many fatty substances on a day continuously, next day our stools may be a little sticky. Such cases this may come falsely positive. So what is a better method? Better method is to quantitatively estimate how much fat is being excreted in the stool. So we will do a 24-hour fecal fat estimation on a standard diet of. So basically the intake of fat is being standardized. Standard diet of 100 grams of fat per day for 3 days. So patient is given a diet which contains exactly 100 grams of fat today, tomorrow, day after tomorrow, and then we will estimate the fecal fat. So if the fecal fat is more than 7 grams, Basavaraj, we will. So if the fecal fat is more than 7 grams per day, it is suggestive of fat malabsorption. If it is less than 7 grams per day, it is not suggestive of fat malabsorption. More than 7 grams per day is suggestive of fat malabsorption. Sure, I will address that. So no fat malabsorption if it is less than 7 grams per day. Okay. No, Shiv, see, we do use, because they are protein digesting enzymes. So in many inflammatory conditions, right, we want to digest some of the locally activated proteins which are contributing to inflammation so that the inflammation comes down. So basically they're protein digesting enzymes, and that's why we're estimating their levels in the protein malabsorption patients. The efficacy of trypsin, chymotrypsin for treating inflammatory conditions is not well established. So that's why we generally don't talk about it when you talk about osteoarthritis, joint injuries and all, but doctors continue to prescribe. Okay, so this is about the evaluation of the malabsorption syndromes. Now, what should I write for the management? Right, so management will take into account two things. First, you have to mention that dietary modifications, and second is nutrient supplementation. Nutrient supplementation. We will write few examples here. So what dietary modifications are required? For example, if the patient is having, let us say if patient is having protein malabsorption, right, what diet I would suggest? Right, we would suggest diet high in free amino acids. so that if the whole protein cannot be digested and absorbed, the free amino acids can be absorbed, right? If there is fat malabsorption, if they're not able to digest the fat because there is pancreatic insufficiency or something, what we can give them? We can suggest diet high in medium chain triglycerides, which can be easily absorbed. We don't need to break them because they're already in broken down form, right? Suggest example is your coconut milk. Coconut milk is high in medium chain triglycerides, so it is easy for them to absorb the fat. Suggest diet high in medium chain triglycerides. And of course, nutrient supplementation based on deficiencies, right? If patient is having B12 deficiency, I need to give them B12 supplementation. If patient is having vitamin A deficiency, I need to give them the vitamin A supplementation. Okay. See, the free amino acids are available as a supplement, right? Branch chain amino acids, essential amino acids, they're available as powders, supplements, which we can ask the patient to consume on a regular basis, or the food which is partially digested or fermented will be having free amino acids. Just to give you an example, right? Soya chunks are very rich source of protein. But if a patient is having protein malabsorption, he will not be able to absorb those soya chunks. But there is also a version of soya chunks called as tempeh. What is tempeh? It is a pre-treated or fermented version of soya chunks where the protein will be broken down to smaller peptides and some free amino acids. So breaking down work is already done to some extent. So if patient is having pancreatic protease deficiencies, he will still be able to absorb reasonable amount of these amino acids and smaller peptides. Okay. And nutrient supplementation will be based on deficiency, where you can mention the list like vitamin A, vitamin E, whatever the nutrients the patient is deficient, we should be supplementing. Okay. And then the third choice is also, we can give them TPN. What is TPN? TPN stands for total parenteral nutrition. Total parenteral nutrition, or better to write total or partial parenteral nutrition. Partial or total parenteral nutrition. This is not required for all patients, but those who are extremely malnourished and they have severe malabsorption, they are not able to absorb proteins, fat, the carbohydrates, vitamins in them, to restore the body's balance or to restore all the nutrients to the optimum levels. First, we have to give them through injectable forms, right? That is what we call as parenteral nutrition. If all the micro macro is coming from the injectable only, we will call it as total. Or if some is coming from injectable and rest is coming from the diet and oral supplementation, then we will call it as partial parenteral nutrition. So that completes our description of malabsorption syndromes for a 5 to 7 mark question. Now let's go to the next question, which is very commonly asked for most universities, that is about IBD or inflammatory bowel disease. The questions usually go like this: define IBD, describe briefly about the ulcerative and Crohn's disease, and write short note on its management. Okay, so तब कोशिश करता हूँ. Okay, so what is IBD? IBD का मतलब क्या है? Inflammatory bowel disease. How is it different from irritable bowel syndrome? Irritable bowel syndrome was a functional disorder. This is an organic disorder. Problems है यहाँ पे, right? So we will define it as a chronic, possibly autoimmune inflammation of bowel and other organs presenting with bowel related symptoms and malnutrition. Bowel related symptoms and malnutrition. This is a simple summary of what is inflammatory bowel disease. What points you should cover? Chronicity, right? Possibility of an autoimmune nature, inflammation, and bowel. Okay. Now, how do I classify IBD? IBD is of many types. For an undergraduate student, of course, two are important, which is ulcerative colitis and Crohn's disease. But you should also write the other two, not so common, but still just for the sake of completion. So first we will mention ulcerative colitis. Second is Crohn's disease. Crohn's disease. Third one is lymphocytic colitis. Lymphocytic colitis. And the fourth one is collagenous colitis. Collagenous colitis. So for the theory exam, don't bother about what is lymphocytic colitis and collagenous colitis. You are not expected to write about it. Ulcerative and is Crohn's is what you need to know. So TPN is not for the long-term solution. It is only for the initial loading, because when patients of malabsorption syndrome are diagnosed, right, they will be severely depleted reserves or stores of the micronutrients in the body. So to replenish them, sometimes you might have to take them on the TPM. But once the initial replenishment is done, the long-term management, of course, cannot be through TPM. TPN has a lot of long-term complications. The insertion site often gets infected. We many times need to use the central line, which gets infected. And the nutrient profile that we can get from the diet, we cannot mimic that through the total parenteral nutrition. Some electrolyte abnormalities are known to happen. So it's not a long-term solution. It is temporarily to load or replenish the depleted stores of nutrients. After that, for maintenance, of course, it is always about diet and regular supplementation. Okay. So these are the 4 types of inflammatory bowel disease. Before going forward, right, we have to understand a little bit about the ulcerative colitis and Crohn's disease, so that remembering the rest of the things becomes easier. So when you look at the names of these diseases, one is called as ulcerative colitis, right? And the other one is called as Crohn's disease, not Crohn's colitis. No, the irritable bowel syndrome is not autoimmune. We will label some disease as functional only when major structural and biochemical abnormalities are ruled out. So that means there is no major biochemical abnormality, there is no antibodies, there are no antigens, and no structural abnormality. There is no stricture, fistula, inflammation, nothing. That's why it is called as functional. Other examples for functional disorders I can quote is like the fibromyalgia. That's also a functional functional disorder. Then chronic fatigue syndrome. So you don't have any evidence to say that this is the pathology. We can have some theories, but no solid biochemical abnormality or structural abnormality identified yet. Okay. Coming back to the topic, why ulcerative colitis is called as colitis and why Crohn's disease is called as Crohn's disease. I can also call it as Crohn's colitis, right? There's a reason. What is the reason? Ulcerative colitis, the inflammation is restricted to the colon. Crohn's disease can affect anywhere from mouth to the anus. It can affect any part of the GIT, right? So ulcerative colitis mainly affects colon. And Crohn's disease affects any part of GIT. It affects any part of gastrointestinal tract. Okay. Just some visual representation here for pleasing the examiners. The ulcerative colitis is characterized by involvement of the entire colon. Means whenever ulcerative colitis affects, it starts the disease process in the rectum and then ascends up. As it is ascending up, it goes on involving every region. Right? It is not leaving behind an unaffected island of colonic tissue. So if I have to represent it, I would usually represent it like this, right? Let us say I am dealing with a patient with ulcerative colitis. This is my rectum, right? So ulcerative colitis starts in the rectum, and as it spreads upwards, it starts in the rectum. As it spreads upwards, it goes on involving the entire region of the colon. It will not spare any tissue unaffected. It can go up to the terminal ileum. Generally does not involve the terminal ileum. On the other hand, what Crohn's disease does is, Crohn's disease, it tends to not involve the rectum much. The most commonly affected part in the Crohn's disease is primarily the terminal ileum and the rest of the colon. So it starts here, and then when it involves rest of the colon, it will involve in a segmental manner. Means some segment is affected, some segment is spared, and rectum is generally spared. Yes, the ulcerative colitis is mainly the colon and rectum. It is not affecting the small intestine. Crohn's disease can affect anywhere from mouth even oral cavity lesions are known to happen, esophagus, stomach, small intestine, as well as the colon. But rectum is usually spared, very rarely involved. Second thing that we are noticing here is when inflammation escalates, it is leaving behind unaffected areas, right? So there is a segmental involvement. There's a segment which is affected, there's a segment which is not affected. So these islands of unaffected regions, we will call them as skip lesions, right? We will call them as skip lesion, right? It is the Crohn's disease lesion here where there is inflammation, but some areas are skipped, so we'll call it as skip lesion. As you see here, there is involvement of terminal ileum and the rectum is relatively spared. These points we will write also down in the answer, but when we give a visual representation, examiner understand that the student knows it. You don't have to read through your lines. Okay. So this is the basics that we need to know. Ulcerative colitis means colitis only. Crohn's disease means beyond colitis, right? Any part of the GIT can be affected. Now, in terms of epidemiology, what points I should mention? The first thing we should mention is that it is more common among jeeves. Among jeeves. The jeevish population has higher prevalence of the inflammatory bowel disease, right? The second thing that I wanted to mention in the epidemiology, some things are protective against ulcerative colitis and some things increase the risk of Crohn's disease. So second thing I want you to write is smoking. Smoking is protective for ulcerative colitis, but smoking increases Crohn's disease risk. Okay. Then third thing that I want you to write is appendicectomy. Appendicectomy protects against ulcerative colitis. Protective for ulcerative colitis. So basically there is some or the other thing protecting ulcerative colitis. There is nothing protecting you from Crohn's disease, right? No effect on Crohn's disease risk. Okay. Then fourth, use of oral contraceptives is associated with increased Crohn's disease risk. Increased Crohn's disease risk. And the fifth one, use of antibiotics in the first year of life. Antibiotics in first year of life is associated with increased risk of both Crohn's as well as increased risk of ulcerative colitis as well as Crohn's disease. So in simple words, there are things which protect from ulcerative colitis, which is smoking and appendicectomy, but there is nothing protecting you against the risk of Crohn's disease. And equally important is that smoking is not protecting you from anything in life. Means it seems like it is protecting you from ulcerative colitis, but it is increasing your risk of Crohn's disease. So the end result is you are having increased risk of inflammatory bowel disease, right? You are not getting any benefits. Similarly, there are few studies which say that smoking decreases the risk of Alzheimer's disease. Very few small studies, but the truth is no. Why? Because smoking can make sure that you don't live long enough to develop Alzheimer's disease. So that way, yeah, it protected you from Alzheimer's disease, but it didn't protect you from your mortality. So stay away from smoking and don't think that it is going to do anything great for you. Okay. So this is the important epidemiological point that we need to mention. After the epidemiology, we'll start with the clinical features, and the best way to represent ourselves on the paper is trying to compare ulcerative colitis and Crohn's disease side by side. So that way you're telling the examiner that I know the stuff more precisely and मैं सिर्फ हवा में नहीं छोड़ रहा. Okay. So in terms of clinical features, first let us mention ulcerative colitis patients. Ulcerative colitis patients, the most common presenting complaint is blood and stool, right? That is bloody diarrhea. Okay. Apart from that, they can also present with abdominal pain. And for the Crohn's disease, The most common presenting complaint is fever. Presenting complaint is fever. These patients present with fever. Other than that, they can present with abdominal pain, and they can have perianal fistulae. Perianal fistulae. Okay. Now I probably forgot to tell you what is the fundamental difference between ulcerative colitis and Crohn's disease process. So in ulcerative colitis, the inflammation that we do, see, it is restricted to the lamina propria, means it is like mucosa and little bit lower regions. But in case of the Crohn's disease, the inflammation is transmural. So now what do I mean by that? Transmural means entire thickness of the bowel is inflamed, right? And because of that, bowel tend to develop the small ulcers which eventually penetrate and develop a fistula. So fistula formation is very common in patients with the Crohn's disease. We don't get to see fistulae in ulcerative colitis because the inflammation is not spreading for the full thickness of the colon. It is spreading only to the superficial layer, which is the lamina propria. Okay. So this is about the clinical features. Now coming to how do I make a diagnosis. But before going to diagnosis, let us write some comparison about the ulcerative colitis and Crohn's disease. Ulcerative colitis and Crohn's disease. Okay, we will do that comparison when we go to histopath itself. We can write it under that heading also. Okay, so for diagnosis, we will start with 1. Serological markers. What serological or blood investigations I can do for diagnosis of ulcerative colitis or Crohn's disease, and what will be considered as the investigation of choice. So under serological markers, I want you to write 2 things. First thing is fecal calprotectin. Now what is it? Just like how we have ESR and C-reactive protein as a marker of generalized inflammation in the body, fecal calprotectin is a marker of inflammation of your intestines or the bowel. So if there is bowel inflammation, the fecal calprotectin level will be elevated. It's an inflammatory marker, right? So what is it? It's an inflammatory marker. It's an inflammatory marker. So if it's an inflammatory bowel disease, inflammation should be there. So fecal calprotectin will be elevated. This is one investigation that we generally do whenever we are suspecting irritable bowel syndrome, because I want to rule out IBD. I will do a fecal calprotectin level. If it turns out to be normal, then IBD is little unlikely. I'm now more leaning towards IBS as a diagnosis, right? Second thing, yes, we can do ESR, CRP on a regular basis also for understanding the fluctuations in the disease process. But in the exam, we're writing more specific terms. You can definitely fill more lines by writing about ESR, CRP as well, right? We will also do some antibody markers. One is anti-Saccharomyces cerevisiae antibody, and the third one is P-ANCA. P-ANCA. Anti-Saccharomyces cerevisiae will be usually positive in Crohn's disease, and P-ANCA will be usually positive in ulcerative colitis. P-ANCA will be usually positive in ulcerative colitis. Okay, but what is the investigation of choice? Investigation of choice is not serology. Serology can lead you towards the diagnosis, but the investigation of choice will be colonoscopy plus biopsy. Colonoscopy plus biopsy. So what colonoscopic findings I can get? Colonoscopic findings or the gross appearance, right? So let us write them for ulcerative colitis and for the Crohn's disease. So what findings I will get in ulcerative colitis? As I've already told you, ulcerative colitis is the condition where inflammation is restricted to lamina propria, right? So what am I going to see here on under the colonoscopy? 1. Mucosal friability. So what do I mean by that? The mucosa is very vulnerable for injury. So when an endoscopist is doing the colonoscopy, even when the colonoscope brushes against the mucosa, it may cause some tear and it may result in bleeding. That's why these patients generally present with, what is the presenting complaint of ulcerative colitis patients? It is usually bloody diarrhea, because their mucosa is inflamed and highly vulnerable for the injury. So the moment you brush it, it may injure and start bleeding, right? On the other hand, we mentioned most common presenting complaint of Crohn's disease as fever. mucosal friability. Second, loss of mucosal vascularity. Mucosal vascularity. So the blood vessels in the mucosa may not be clearly visible as blood vessels running there because of the edema and inflammation. And third thing that we can see is loss of ostrations. Loss of ostrations. Because see, just think, when you look at your skin, there may be some wrinkles, right? But when the skin becomes inflamed because of the edema, the wrinkles disappear. Same, we have ostrations inside the colon, but once the mucosa becomes highly inflamed and edematous, those ostrations will disappear. And that actually leads to a radiological finding, what we call as the, what is the radiological finding known as lead pipe colon or pipe stem colon. Okay. Then fourth, you will have ulcers which are superficial, Okay. Fifth thing, this inflamed mucosa can start pouching out like balloons. We will call them as pseudo polyps. On the other hand, in Crohn's disease, the Crohn's disease includes or involves all the layers of the bowel. So you will have a transmural inflammation. So in Crohn's disease, what I will see is, I will see ulcers which are more deep and running like a snake. So we will call them as aphthous ulcers. We are calling them as aphthous because they are deep. They are aphthous ulcers which are also serpiginous. So think of it like this is a colon I'm looking at, and then there is a snake-like deep ulcer which will eventually heal with fibrosis. There will be another snake-like deep ulcer which will heal with fibrosis. Another snake-like deep ulcer which will heal with fibrosis. Another snake-like deep ulcer which will heal with fibrosis. So when that happens, eventually what happens, you have a lot of streaks of fibrosis, and nestled between these fibrosed healed ulcers, we have normal mucosa. So healed fibrosed ulcer, and this is normal mucosa. Good evening. So this under the endoscope looks like cobble stoning, right? So second thing I can notice in Crohn's disease is under the endoscope I can see cobble stoning. Third, there will be segmental involvement, means some segment is affected as we have already discussed, with some regions not affected, so we will call it as skip lesions. So under the endoscopy, what examiner is looking for, he wants the word skip lesions and cobble stoning for Crohn's disease. He wants the word pseudopolyps, right? Mucosal friability and loss of ostrations for the ulcerative colitis. Okay. This is endoscopic appearance. Of course, from here we will go to the biopsy or histopath, right? What histopath is going to reveal, or what I as an examiner expect on the question about inflammatory bowel disease. So I just want you to mention for ulcerative colitis and for Crohn's disease. For ulcerative colitis, I want you to mention that there will be inflammatory infiltration of lamina propria. It is restricted to lamina propria, and there is continuous involvement without skip lesions. On the other hand, in Crohn's disease, you have to mention that there are skip lesions or there is segmental involvement, and it is the transmural inflammation. So in Crohn's disease, it is transmural inflammation, and here there is segmental involvement with skip lesions. And the third thing we have to mention is that whether there are granulomas present. So there are no granulomas in ulcerative colitis, and you do have non-caseating granulomas. Basically, Crohn's disease is a non-caseating granulomatous inflammation. Ulcerative colitis is a non-granulomatous inflammation. Non-caseating granulomas present in the ulcerative colitis. Okay. So that explains our histopath findings. So with this, we have established that it's a patient with ulcerative colitis. So for diagnosis, what all we have utilized? We have utilized the serological markers. The currently accepted inflammatory marker or the preferred inflammatory marker is calprotectin, anti-Saccharomyces cerevisiae antibody, and P-ANCA. Investigation of choice, colonoscopy with biopsy. Biopsy in Crohn's disease, there is full thickness inflammation with segmental involvement, skip lesions, and granulomas. And on the other hand, in case of ulcerative colitis, there is no segmental involvement, there is continuous involvement, no skip lesions, and inflammation is restricted to lamina propria, and it is just the lymphocytic infiltration. There are no granulomas. Okay. So with this, our diagnosis is established. Now, how do we manage a patient with inflammatory bowel disease? So if I have to manage ulcerative colitis differently and Crohn's disease differently, right? Okay, before management, let us also talk a little bit about complications, and then we can talk about the management. So what complications this ulcerative colitis can lead to, apart from the presenting complaints that we discussed? Patient with ulcerative colitis will present with bloody diarrhea, and patients with Crohn's disease will present with fever or perianal fistulae with the discharges. But what else it can cause, right? So there are a lot of complications that inflammatory bowel disease can lead to. So those complications, let us classify them into intestinal and extra-intestinal. Intestinal and extra-intestinal. So what comes under the intestinal complications? So the first thing that I want you to mention is there is something called as toxic megacolon. Toxic megacolon. So what is toxic megacolon? See, the mucosa in Crohn's disease is not very friable. See, like how would I describe it? If skin gets inflamed, right? If it is because of trauma, the skin is already traumatized and then you have inflammation, but the trauma is resulting in bleeding. But on the other hand, if I have a blunt injury to the skin, right, I may not bleed. There is inflammation in both the cases when I have a blunt injury and a traumatic injury. Both cases, there is inflammation, but bleed will happen when the skin is traumatized. Similarly, because in ulcerative colitis, the intensity of inflammation is primarily targeting the mucosa. Mucosa is highly friable or vulnerable to injuries. Even the passage of the stool can injure it, and that's why they bleed. That's why I said, even while doing the endoscopy, you just brush the mucosa, sometimes it starts bleeding. On the other hand, Crohn's disease, the intensity of inflammation is distributed the whole thickness. The mucosa is not so much inflamed, and that's why we don't get to see so many pseudopolyps either in the Crohn's disease, right? So that's why the bleeding probability is less. But because it is granulomatous and transmural, the ulcers are deep and they can perforate. And when they perforate, slowly a fistulizing tract can be formed. That's why Crohn's disease usually present with fistula. And because it is again deep-seated ulcers, when they heal, it can lead to fibrosis and strictures. So strictures and fistulae are little uncommon in case of ulcerative colitis because the inflammation is only restricted to lamina propria. Okay. So one of the complications that affects the intestine in the patient with inflammatory bowel disease is toxic megacolon. What does it mean? It means acute inflammatory dilatation of the colon. It means acute inflammatory dilatation of colon. When do I call it as toxic megacolon? When the transverse colon diameter is more than 6 centimeters. We will call it as toxic megacolon. This is typically more common in ulcerative colitis patients. It is more common in ulcerative colitis patients. Okay. Second thing with respect to intestines, it can cause is there is fistulae and stricture formation, which is more common with Crohn's disease, Okay. Third thing, there is increased risk of carcinoma of the colon. So IBD is a pre-malignant condition. There's increased risk of carcinoma of the colon. The risk is more in ulcerative colitis in comparison to Crohn's disease. Risk is more in ulcerative colitis in comparison to Crohn's, but both increase the risk of cancer. These are intestinal complications. Rajendra, very good, very good. You can also mention one more point here for the toxic megacolon. There is a risk of perforation because there is such an acute dilatation, the bowel will not be able to hold on. There is a risk of perforation. So this can be considered as a life-threatening complication of the ulcerative colitis. Now, what extra-intestinal complications I can expect? These we can list system-wise. So the first thing is musculoskeletal. Musculoskeletal. What musculoskeletal complications I can get? So musculoskeletal complications wise, it can lead to arthralgia, joint pains. It can lead to oligo or polyarthritis. And when I say oligo or polyarthritis, it can include axial as well as extra-axial skeleton. Now, what do I mean by that? The spine is our axial skeleton. The limbs are our extra-axial skeleton. So it can affect any of them. So in fact, a good number of patients with inflammatory bowel disease present with what is called as enteropathic arthritis, which is a subtype of spondyloarthritis. It's a subtype of spondyloarthritis. Okay, not required for your theory exam, but for MCQs, you need to know. Okay, then what else it can affect, right? Can inflammatory bowel disease affect skin? Yes, it affects skin. So what findings I get in skin? So in the skin, I want you to write two findings. The first is in the skin, it can cause what is called as pyoderma gangrenosum. And the second one is erythema nodosum. Two extra points will give you some brownie points in the eyes of the examiner. The first thing I want you to write about pyoderma gangrenosum is it is more common in ulcerative colitis than Crohn's disease, and erythema nodosum is more common in Crohn's disease than ulcerative colitis. These points, if you are not able to remember for the theory exam, it's absolutely okay as long as you are listing it. But for MCQs, these are all subtle nuances that you need to know. The extra point that I want you to mention is that pyoderma gangrenosum does not correlate with bowel inflammation. So if I have got an ulcerative colitis patient and he has got pyoderma gangrenosum, it doesn't mean that his bowel inflammation is very severe. But if I have erythema nodosum in a patient with Crohn's disease, it means that his inflammation is severe because it correlates with bowel inflammation. It correlates with the bowel inflammation. Okay, clear? Then, after the skin, is there any involvement of hepatobiliary system? Hepatobiliary system. Yes, there is increased risk of primary sclerosing cholangitis. Primary sclerosing cholangitis, which is typically more common in ulcerative colitis than Crohn's, right? More common in ulcerative colitis. Crohn's disease, it can happen, but it's quite rare. It's more common in ulcerative colitis. Okay. What renal manifestations I can expect? So renal wise, first thing you should mention is there is increased risk of renal amyloidosis. And the second one, for those where surgical management was done, where bowel resection was done. So for surgically managed patients are at increased risk of developing, oxalate stones, right? Oxalate calculi. Okay, so these are some extra intestinal complications that we can mention. Okay, so that completes our clinical features and comparison between ulcerative colitis and Crohn's disease. Now coming to its management. Okay, management. So we'll take it one by one. First, we'll start with the ulcerative colitis, because these are two entirely different disease processes. The management is also going to be different. Okay. So how will I manage ulcerative colitis? So step one is to classify severity. So how do I classify severity? It will be based on true love and Witt's criteria. True love and Witt's criteria. So what it says, it primarily looks at the number of bloody stools per day the patient is having. Number of bloody stools per day. Okay. So if it is more than 6 per day, it is severe. If it is less than 4 per day, it is mild. And if it is between 4 to 6, then it will be called as moderate. Okay. So now how will I treat? So for mild to moderate patients, these patients, the first line management, what drug do we use as the drug of choice for treatment of ulcerative colitis? What is the drug? Dr. Rajendra, yes, there is also increased risk of gallstones. And for the severe patients, need to be hospitalized, IV corticosteroids for induction of remission. What do I mean by that? First, give the steroids to control the inflammation, because these patients may anytime end up with more severe complications. They may bleed profusely or they may develop toxic megacolon. So first, control the inflammation by giving IV corticosteroids for induction of remission. And then again, you can use, what is the drug of choice for the simple mild or moderate case of ulcerative colitis? You can use 5-amino salicylic acid derivatives like mesalamine, right? That's just to give an example. Second line agents, we can consider using drugs like immunosuppressants. So if the mesalamine or any other 5-amino salicylic acid derivative is not giving the remission, then we can use immunosuppressants like 6-mercaptopurine or azathioprine. And as a third line agent, what I can use, if they're not responding to immunosuppressants also, we have some relatively new drugs like ustekinumab or vendolizumab. Okay, for severe patients, once the remission is achieved, we will follow the same path that we followed for the mild moderate cases. But for initial things, we need to use IV corticosteroids at relatively high doses to cut the inflammation quickly. So that is going to be our ulcerative colitis. The route of administration of 5-ASA derivatives depends. If it is ulcerative colitis where the inflammation is restricted to the rectum is invariably involved, right? So I can also give in the form of parenteral, in the form of per rectal, right? Enemas or suppositories. If it is extending beyond the rectum, then I might have to think of giving oral, right? So the route of administration varies, but otherwise the drug of choice is going to be 5-ASA derivatives. Now, how will I manage Crohn's disease? For Crohn's disease, I have to see whether it is only inflammatory disease or whether it is fistulizing disease or whether it is we will classify them into 3 groups. One, we will call it as B1, which is just inflammatory disease. Only inflammation is there. Second is B2, where we have stricturing Crohn's disease, where stricture formation is happening, stricturing Crohn's disease. And third, we will have B3, or where we have fistulizing Crohn's disease. Fistulizing Crohn's disease. So in terms of severity, it is the B3, the fistulizing, which is the most aggressively behaving disease. So what do we do for them? We follow what is called as top-down approach. Means what? Just like how a severe ulcerative colitis, we try to first manage the inflammation very aggressively, then step down with the conventional treatment. Here also, fistula formation means very aggressive disease. So first we try to control the disease process, then we will switch to maintenance. Right? For these patients, we can follow what is called a step-up approach. Means start with the first line agents. If they are not helping, go to second line. If they are not helping, go to third line. Okay. So for fistulizing disease, the treatment of choice will be what we call as top-down approach. Now, what do we do in top-down approach? We will have induction with TNF alpha blockers. Can anybody give me examples for TNF alpha blockers? We can have drugs like adalimumab, infliximab, these are all TNF alpha blockers, right? Or golimumab, certolizumab, pegol, we can use. For maintenance, once I've used these potent drugs and the inflammation is controlled. So for maintenance, I can use the ASA derivatives or 6-mercaptopurine or azathioprine or even TNF alpha blockers. So that is how we try to manage. So I'm using the best possible potent drugs to initially control, right? I can also use drugs like tofacitinib, which is an interleukin 6 blocker. So these are the choices I have. So the approach is what is important here. So what are we trying to do? We are not trying to see whether a mild drug works for the patient. No, we are first using the best weapons available, control the disease. After that, we are switching down to milder medications, right? So for inflammatory disease, where there is no strictures, no fistula, just Crohn's disease, just inflammation, just some episodes of fever, right? So for such patients, we will follow the step down approach, step up approach. So what we do here, so first line that I can follow here is usually going to be 5 ASA derivatives. That doesn't help. As second line, I can think of 6-mercaptopurine or azathioprine or other immunosuppressants. And as third line, if they are not helping, then only I can think of TNF alpha blockers. But for the stricturizing disease, we can either follow step up or top down approach. Anything I can do depending on the severity. So if I'm following the top down approach, this is what I'm doing. If I'm following the step up approach, this is what I'm doing. So for stricturizing disease, I can take one of the route. But for the fistulizing, it's always top down, and for inflammatory, it's always step up. So that completes our treatment of the inflammatory bowel disease. So as long as patient respond to the mesalamine or any of the 5 ASA derivatives, it's not very expensive. Even azathioprine is not expensive, or 6-mercaptopurine is not expensive. But once we start stepping into monoclonal antibodies, any disease right now, monoclonal antibodies are damn expensive. So that's about our IBD. Let's go to the next question. So what is our next question? The next question is on celiac disease. Write a short note on the clinical features, diagnosis, and management of celiac disease. Right? We will begin with the definition. What is celiac disease? So celiac disease is primarily it's a gluten sensitive, it's a hypersensitivity reaction. In other words, it's a gluten sensitive enteropathy predominantly affecting duodenum, predominantly affecting the duodenum, presenting as abdominal pain, diarrhea, or dyspepsia, often along with malnutrition of micronutrients. So this is not a simple disease where patient has some abdominal pain and some discomfort or constipation, diarrhea. Of course, patient will have abdominal discomfort and other symptoms which brings them to the hospital. But because there is significant inflammation of the affected segment, whatever nutrients that get absorbed there will not be absorbed and patient will present with malnutrition. Okay. So what clinical features we are expecting? The clinical features of celiac disease, let us classify them into intestinal and extraintestinal. So intestinal में क्या क्या आएगा? First one is abdominal pain. Second, diarrhea. And both of these symptoms are usually after consuming gluten-rich food, right? If you want, you can mention few food items like wheat, barley in the bracket as gluten-rich food. What extra-intestinal manifestations I'm going to get? This is what you need to write in more detail. Okay. So first thing, the celiac disease presents with iron deficiency anemia, right? Why they are presenting with iron deficiency anemia? The point we have to remember here is that celiac disease predominantly affects what part of the GIT? It predominantly affects the duodenum. Predominantly affects the duodenum. Why is it predominantly affecting the duodenum? Because the gluten that we eat, right? It has to be broken down to a peptide called as gliadin. So when we eat gluten, this gluten gets broken down to a peptide called as gliadin by an enzyme called as tissue transglutaminase. And once this gliadin peptide is formed, some of us may be allergic to this gliadin. So such individuals, now they will develop antibodies against the gliadin. That's what we will call as anti-gliadin antibodies. Many individuals will also have anti-TTG antibodies. So now these antibodies will start damaging the area of the bowel wherever gliadin is present, right? Now where I will have the maximum amount of antigen present in the digestive tract, where I will have the gliadin present. So stomach starts digestion of the protein. The maximum amount of gliadin is presented to the duodenum, right? As the food bolus moves forward, lesser and lesser exposure to the gliadin or gluten, and that is why lesser or lesser antibody mediated injury. So the maximum antibody mediated injury happens to the duodenum, right? So always when you think of celiac disease, think of duodenum. Why that is important? Because iron absorption predominantly happens in the duodenum. So if duodenum is inflamed, I may not be able to absorb iron sufficiently. Gluten is a protein. It's a protein. So whenever you eat chapati, right? Chapati is stretchy. The stretchiness comes from the gluten itself. So if I remove gluten, it's very difficult to make chapatis from the wheat because that stretchiness or the binding agent is gluten. It's a hygroscopic protein. It holds a lot of water. That's why you get nice dough and make very fluffy, tasty chapatis. Okay. So as I told you, that gliadin is one of the digested peptide. Means when I break down gluten into smaller peptides, one of those peptides is gliadin. Okay. So iron deficiency anemia, refractory to oral iron treatment. Okay. So इसका मतलब क्या है? What do I mean by that? If your duodenum is affected, no matter how much oral iron I take, I will still not be able to absorb it. But the moment you give me parenteral iron, कि हाँ iron injection दे दिया तो मेरा anemia ठीक होने लगेगा. But oral देते रहो, respond नहीं करेगा because there is decreased duodenal absorption, right? It is due to decreased duodenal absorption of iron. Okay. Patients may have folic acid deficiency. Folic acid deficiency, not very common because major amount of folic acid absorption happens in the jejunum, but to some extent it does happen in duodenum. I'm losing that much part, but they don't present with B12 deficiency. Why? Because for B12 I need only two things: one, stomach, which produces intrinsic factor of Castle, and the acidity of the stomach is necessary. And then the absorption happens in the terminal ileum, which is not affected because the amount of gluten or gliadin that can reach the terminal ileum is negligible. Before that only, it is acted upon by the digestive enzymes and broken down to smaller proteins. So that's why duodenum is most affected, terminal ileum is almost not affected. So I will not have B12 deficiency. Okay. Then third, patients with celiac disease also develop arthritis. It is very common. Okay. Fourth, there is involvement of skin. The skin involvement is in the form of a vesiculous rash called as dermatitis herpetiformis. Dermatitis herpetiformis. Okay. Then celiac disease also affects the cerebellum. So it causes inflammation of the cerebellum. We will call it as cerebellitis. In fact, the celiac disease is now the second most common cause for cerebellar disorder in adults after stroke. Of course, alcohol is there, but alcohol causes transient cerebellar dysfunction. For persistent cerebellar dysfunction, the leading cause is stroke, followed by celiac disease. Okay. So these are some of the important extraintestinal manifestations. Okay. Now, the point we have to note is mostly children present with intestinal manifestations, present with intestinal manifestations, and adults tend to present with extraintestinal manifestations. Adults tend to present, they won't present mostly saying that, okay sir, after eating chapati I have little abdominal discomfort. They tend to present with all these symptoms. In fact, I have diagnosed plenty of celiac disease patients because their iron deficiency anemia was not responding to the oral iron therapy, and once we started on parenteral, it started responding like anything. So adults tend to present with extraintestinal manifestations. So for that reason, now we call intestinal predominant celiac disease as classical celiac disease, and if the patient is having extraintestinal symptoms as a predominant symptoms, we will call it as non-classical celiac disease. So classical celiac disease refers to predominantly intestinal symptoms, and non-classical celiac disease refers to predominantly extraintestinal symptoms. Non-classical celiac disease refers to predominantly extraintestinal symptoms. Extraintestinal symptoms. Okay. So now let us say that I got a patient who keeps repeatedly coming and telling that sir, चपाती नहीं हो सकता है, चपाती खाता हूँ उसके बाद में पेट में गुड़गुड़ होने लगता है, पेट फुल जैसा लगता है, sometimes diarrhea भी लगता है. Very common complaint. Now, when I get such a patient, my suspicion is that he may be having celiac disease. How will I take it from there to the diagnosis? Or let us say I got a patient, adult, with some dysdiadochokinesia, right? Reeling gait, nystagmus, intention tremor. I will also have celiac disease as one of my differential diagnoses. Now, how will I establish that this is a case of celiac disease, right? So how do we make a diagnosis? So we have some serological tests and biopsy. So serological test, the first thing that we would do is anti-TTG antibody test. Okay. What else we have? We also have anti-gliadin antibody test. Okay. What else we have? We have anti-endomysial antibody test. Okay. And then we have anti-deamidated gliadin peptide antibody test. Okay. So I want you to write only few points. Specifically anti-TTG antibody, right? This is a screening test of choice. It's a screening test of choice. It's a screening test of choice. Okay, so Shivu, the intestines, if I am producing antibodies in the intestines, what antibodies I am producing? Secrete. I have to secrete the antibodies, right, into the intestinal lumen to the job of the antibody. So I'm secreting secretory antibody. So it is mainly IgA, right? And then in the long run, I can have IgG. The initial screening test we do IgA, and when we are doing IgA, we have to also check the patient's serum IgA levels. So if IgG comes positive, it is leaning towards celiac disease. But if it comes negative, it does not rule out celiac disease. I have to also look at the patient's serum IgA levels, because patient may be having IgA deficiency. In that case, the IgA will not come positive, right? So in such cases, I have to think of IgG. Now, all this writing is not expected in the theory exam, but of course, for MCQs, we need to know more precise, finer nuances. For the MCQs, for the theory, as long as you are able to list and write 1 or 2 points about individual antibodies, it is more than enough. It is the screening test of choice. Anti-gliadin antibody is non-specific. It is non-specific, right? Anti-endomysial antibody is specific, is the most specific antibody that we have. Now, anti-DGP, what does it stand for? It stands for deaminated gliadin peptide. It is the antibody which is targeting the gliadin, but after removal of some amine group. So it is anti-deaminated gliadin peptide antibody. This is useful for diagnosis of celiac disease in IgA deficiency patients. Yes, in such cases, you can do the IgG TTG antibody, or even better is to go for anti-DGP antibody. Of course, it is again going to be IgG, not IgA, because if I'm talking about IgA deficiency, it can't be an IgA antibody. And it is also a useful investigation in children less than 2 years and children less than 2 years. Children less than 2 years. Rajendra, right? That is deaminated gliadin peptide. Okay. So the go-to antibody for initial diagnosis is going to be IgA TTG. If IgA deficiency is there, you can go for IgG TTG, or you can go for anti-deaminated gliadin peptide antibody, right? Anti-endomysial is used for more confirmation because it is more specific. Anti-gliadin antibody is non-specific. It is not routinely used. But serology alone is not enough for the diagnosis of the celiac disease, because we will see a lot of patients who are serology positive but biopsy is negative. So you can make a diagnosis of celiac disease only when serology is accompanied by biopsy findings. What biopsy findings we will expect, right? So normally when we look at the intestinal biopsy, we will have some crypts and villi, right? So what happens in the celiac disease? In the celiac disease, the crypts become more deeper, right? So there is crypt hyperplasia. Crypt hyperplasia. There is crypt hyperplasia because the crypts have become more deeper now, and the villi have become flattened. So this we will call it as villus atrophy. Villus atrophy. And the third thing, of course, this is a inflammatory condition, right? So you will have inflammatory infiltration, which is primarily lymphocytes, right? So you will have lymphocytic infiltration. Lymphocytic infiltration. So these are the three things that we need to write in the biopsy. Now, is biopsy specific for the diagnosis? If you want to write, you can say biopsy is not specific for the diagnosis, because same findings I can also get in patients with Whipple's disease. I can also get in patients with any other chronic malnutrition conditions. So the not Whipple's disease, but in Whipple's disease we do get the specific finding. What is it? You have the past positive inclusions, right? So Whipple's disease, we can make a specific histopathological finding. Histopathology in celiac disease is not specific, seen in various other inflammatory conditions. Okay. Now, once I've diagnosed it as a celiac disease, how will I manage? And I forgot to answer one more important point. What is it? Is there any role of genetic testing? Is there any role of genetic testing? Right. HLA DQ2 or DQ8 is associated with increased risk, right? Is there any role of genetic testing? The answer is, one thing we have to mention is that the HLA DQ2 or DQ8 testing has high negative predictive value. Now, what do I mean by that? if you don't have HLA DQ2 or DQ8, one of them is not there, you're unlikely to be a case of celiac disease. Even if you throw this histopath image at me, I would say, sir, no, this is not a case of celiac disease because HLA DQ2 and DQ8 both are negative. So it has a high negative predictive value. It helps you to rule out celiac disease. It does not help you to diagnose celiac disease. It lacks the positive predictive value. Why? Because 25% of India's population is either DQ2 or DQ8 positive. It doesn't mean that 25% of the population has celiac disease or will develop celiac disease, right? So third, we can mention definitely for the completion about the genetics. Genetic testing. So there you can mention HLA DQ2 or HLA DQ8 have high negative predictive value. Useful in ruling out celiac disease. Not useful in ruling in celiac disease. They are helpful in ruling out. If it is negative, it's not celiac disease. If it is positive, it may or may not be celiac disease. Pujari Sai Siva, you can get a NEET PG course on the PW MedEd, and you can also join the PW MedEd Sankalp batch where we also cover the test and discussion. Okay, so now how will I manage the celiac disease patients? Management is simple. Eliminate the gluten from the diet, right? Gluten elimination diet. So you can write like avoid wheat, barley, and whatever else gluten rich food comes to your mind. Second, nutrient supplementation is required. See, the genetic testing can be done on various samples. The blood is the ideal sample from which we can get the genetic material and do the test. Nutrient supplementation, mainly we will require iron and folic acid, right? So severe cases may be helped with short course corticosteroids. Short course corticosteroids. Okay, so that completes our answer for the celiac disease. Again, to give you a summary, what points as an examiner I will be looking for? I definitely want to see the gluten word, right? I want to see HLA DQ2, DQ8 in your answer. I want to see intestinal, extraintestinal complication. I want you to mention that the duodenum is involved. Classical, non-classical words are not important, but for diagnosis, serological test, I want you to enlist and write 1 or 2 points about it. Biopsy, try to sketch to get that 1 extra mark. And then in the genetic testing, the HLA, I want you to mention either the negative predictive value or ruling out. Management, gluten elimination diet is what I will be looking for. Okay. Now, the next question is on Whipple disease, which is a continuation of question from celiac disease. Celiac disease, Whipple disease combined can be made for a 10 marks, or celiac disease alone can be 5 or a 7 mark question. Okay. So now, what is Whipple's disease? Whipple's disease is a chronic infection of the intestines by what is the organism responsible for this condition? By an organism called as Tropherema whippleyi, presenting as chronic diarrhea, malnutrition, and certain extra intestinal complications. Malnutrition and extra-intestinal complications. Just give me a second. I think I lost the screen. Extra-intestinal complications. So first thing in the introduction that examiner is looking for is the mention of the organism. Okay. Now, in terms of clinical features, what you should write here? It will be a brief answer because it is building on whatever you have written for celiac disease. These patients will also have abdominal pain, diarrhea. So they can also have abdominal pain, diarrhea. Because there is malabsorption, they can have steatorrhea, they can have fever, they can have weight loss, and they can have certain neurological manifestations, right? What neurological manifestations? They can have nystagmus because of CNS involvement, right? So they can also have encephalopathy because this organism also affects the central nervous system. Okay. And that can also lead to one more, something called as oculomasticatory myorrhythmia. Oculomasticatory myorrhythmia. So what does that mean? It basically refers to a condition where when patient tries to, like, the eye muscles and the masticatory muscles are in sync because of the CNS pathology which is caused by this Troponema vipulli. And whenever patient tries to do masticatory movements or eye movements, both the muscles will move in sync. So that's why we are going to call it as oculomasticatory myorrhythmia. If you search, you will get plenty of them in the YouTube, patients with oculomasticatory myorrhythmia. And I want you to mention a point here, right? It is diagnostic of Whipple's disease. It's diagnostic of Whipple's disease, means even without biopsy, I can make a diagnosis of Whipple disease if someone presents with oculomasticatory myorrhythmia. That's an important MCQ point for the NEET PG exam. Otherwise, it's just like any other chronic bowel pathology, right? This patient, if he presents with these symptoms, it may be celiac disease, right? It may be tropical sprue, it may be inflammatory bowel disease, or it may be, right, or any other chronic bowel pathology. So diagnosis will be established on biopsy. But if I get someone with oculomasticatory myorrhythmia, I don't have to go for the biopsy, right? So the diagnosis, the investigation of choice will be biopsy. And what biopsy finding I am looking for? Here also you will have the same findings that we mentioned in celiac disease: crypt hyperplasia, villus atrophy, lymphocytic infiltration. In addition to that, we will have pass positive organisms identified, right? This is the thing that you need to mention. So तब समझता oculomasticatory myorrhythmia, इसका मतलब क्या है? Oculo मतलब eyeball, masticatory मतलब mastication, right? Act of chewing. Rhythmia, arrhythmia मतलब इन दोनों के बीच में एक rhythm बन जाता. So if I try to move my masticatory muscles, eye muscles will also contract and I can have a nystagmus like eye movement, or the vice versa. If I try to move my eyeballs, even the masticatory muscles will move. मतलब दोनों को एक साथ जोड़ दिया है. That is the behavior that we see. That is what we call as oculomasticatory myorrhythmia. So biopsy is specific for a diagnosis because we get these Troponema vipulli organisms as staining positive for the pus in the biopsy specimen. Apart from that, we will also have crypt hyperplasia, villus atrophy, and lymphocytic infiltration. Villus atrophy and lymphocytic infiltration. So once I have diagnosed it, how do I manage these patients? The management will take into account. Basically, this is an infective colitis, right? So antibiotics will be the management. How will I manage? Antibiotics need to be in two phases. The induction phase. First, I need to give some strong antibiotics. And because it is chronic infection, the infection can bounce back again. So I need to have some maintenance phase. So induction will be with a drug which is going to be meropenem. Ceftriaxone can also be used, but meropenem would be the better drug. So we will write meropenem only for the theory exam. And for maintenance, we can use trimethoprim sulfamethoxazole, or what you call as co-trimoxazole. Trimethoprim sulfamethoxazole, what is called as co-trimoxazole. Yes, oculomasticatory myarrhythmia is highly pathognomonic for the Whipple disease. So that is enough for the diagnosis. You don't have to go for biopsy if this is a presenting feature in the patient. If it is not there, of course, I have to establish the diagnosis of Whipple disease only on biopsy. Okay. Okay. So that completes our Whipple's disease. We will move to the next question, which is from hepatology, which is about non-alcoholic fatty liver disease. Okay. Now, in the recent literature, we have started replacing this term non-alcoholic fatty liver disease to metabolic dysfunction associated fatty liver disease, because it's not just that fatty liver happens in an individual who doesn't drink alcohol. Fatty liver happens in an individual who has metabolic dysfunction, who has insulin resistance, obesity, overweight, right? High caloric intake, high carb intake. That's why the term has been replaced by MAFLD, which stands for metabolic dysfunction associated fatty liver disease. So examiner may throw any word at you, you should be familiar, right? Now, what is it? There is accumulation of fat in the liver, but when I have to write it, I have to be more objective, right? So when more than 5% of hepatocytes are fat laden, or they contain fat, in the absence of alcohol consumption. There is little quantification here. For the theory exam, we don't need to write. If the patient is taking two drinks or less than that per week, it will still be considered as non-alcoholic fatty liver disease. If he is taking more than that, we will call it as alcoholic fatty liver disease. We'll just keep it simple in the theory exam. If I get someone whose total number of hepatocytes, out of that more than 5% have fat stores in them, and the person doesn't eat significant quantity of alcohol or alcoholic beverages, then I will call it as non-alcoholic fatty liver disease. Now, what are the risk factors for someone to develop this? The risk factors are, okay, so the first one is obesity, insulin resistance. So basically, fatty liver disease, you can think of it in this way. Let us say there's an individual who is consuming way more than the amount of calories he is burning. And physics, the Newton had told, not Newton, the Einstein had told that energy can neither be created nor destroyed. It can be transferred from one form to other. So if I took a lot of calories in, either I have to spend it or save it in some way, right? And the way we save it is in the form of glycogen and fat. So if I'm taking too many extra calories, body will store some glycogen, but the amount of glycogen I can store in my liver and muscles is limited. So any extra calorie, where should I store it? I will store it as fat. What will be default choice? Subcutaneous fat. But as that starts getting saturated, parallelly, I'll start looking for other places to store the fat, and one of them will end up becoming liver. So in the liver cells, I start storing fat. So basically, we can say that fatty liver begins by excessive calorie consumption. Okay. So that's why obesity is the single most important risk factor. Apart from that, insulin resistance. Insulin resistance. Okay. What else can increase the risk of developing fatty liver? Yes, the sedentary lifestyle. Sedentary lifestyle. Gender, racial disparities are there. For a theory exam, it's not important. Rajendra, very good. Yeah. See, for the theory exam, try to keep it as simple as possible. I'm not going to make it very objective, because you will not get sufficient time to write so much that you have learned in a 1 hour lesson of fatty liver disease. You have to write it for 10 marks. So you can maximum give 15 to 18 minutes to try to deliver the key points. But of course, for the MCQ based exam when you are preparing, you need to know things objectively, right? So in the Farre, we are trying to focus on writing the stuff quickly for the exam. Okay. So now what complications it can lead to? NVK we will get back. We will get back on the redirection series. We'll be starting back again in a couple of weeks. Okay. So what complications the fatty liver disease can lead to? So it can lead to mainly hepatic complications. What complications it can lead to? The fatty liver disease can lead to one. So if I have fatty liver disease, which we have already defined it as more than 5% of hepatocytes having fat. Okay. As the hepatocyte starts getting stretched with the fat, body will try to it will trigger an inflammatory response and we will try to cause inflammation of those fat loaded hepatocytes. So it will lead to hepatitis now, right? We will call it a steatohepatitis. And because here it is non-alcoholic, we will call it as non-alcoholic fatty liver disease as NAFLD or MAFLD. And then this we will call it as non-alcoholic steatohepatitis. So why inflammation is happening? Because the cells are fat loaded, they are being morphologically distorted, and it is triggering the inflammatory response. So at this point of time, we will call it as NASH, right? Non-alcoholic steatohepatitis, or in modern terminologies, we can also call it as MASH, metabolic dysfunction associated steatohepatitis. And as we heal from inflammation, there will be some degree of scarring or fibrosis, right? So we can start developing fibrosis. So fibrosis is a well-known complication of chronic NASH, and from fibrosis we can eventually end up with cirrhosis of liver, right? Cirrhosis is nothing but more extensive form of fibrosis, and we know that cirrhotic liver is a risk factor for development of hepatocellular carcinoma. So if I start eating too much today, eventually I push the risk of fibrosis, cirrhosis and hepatocellular carcinoma onto me. So can I say that non-alcoholic fatty liver disease is associated with higher mortality? Yes, it is associated with higher mortality. So the first complication I would mention is this. Second, the non-alcoholic fatty liver disease is also associated with type 2 diabetes mellitus, because it indirectly tells you the liver may not be directly causing the type 2 diabetes mellitus, but it tells you that you're on the path to develop diabetes mellitus. You're eating a lot of calories, that's why your liver is getting loaded with fat, parallelly you're developing insulin resistance, so eventually you are going to become type 2 diabetes mellitus, right? Then it is also associated with increased risk of mortality. So that means the non-alcoholic fatty liver disease is not a benign entity. It definitely carries adverse outcomes, right? So what clinical features I expect these patients to present with? So in the NAFLD stage, they are mostly going to be asymptomatic, right? So at NASH stage, they may have some symptoms, and as they progress to cirrhosis, of course, there will be features of the liver failure. So at NAFLD stage, mostly they are going to be asymptomatic, but once there is inflammation, they can have mild right upper quadrant pain or sensation of heaviness. Beyond that, again, they may not have much symptoms, but once the cirrhosis sets in, they can have features of portal hypertension, and they can have features of hepatocellular failure. So what are the features of hepatocellular failure I should be writing in the question? I can mention like jaundice. Then I can mention that patients can have gynecomastia. Why are they having gynecomastia? Because there is increased conversion of testosterone to estrogen in the failure of liver cells. Then I can have spider nevi, which is again because of the vascularity, which is because of excess estrogen, which is happening because of conversion of testosterone to estrogen. Right, yes, I can have hepatic encephalopathy, because conversion of ammonia to urea is to be done by liver. Ammonia is toxic to brain. It gets converted to urea so that kidney can eliminate. So this job is done by liver through urea cycle. But if liver is dysfunctional, we will not be able to convert ammonia to urea. So this excess ammonia affects the brain function. So I can have hepatic encephalopathy. It is also contributed by portal hypertension. So hepatic encephalopathy is contributed by portal hypertension. Okay, what features I can see with because of portal hypertension? Esophageal varices. I can see ascites, right? Then we can get something called as caput medusae. Caput medusae. So these are all features of portal hypertension. Just list 3 or 4. That will be more than enough for the written exam. Okay, so if I suspect that someone is having non-alcoholic fatty liver disease at any stage, NAFLD to cirrhosis, right? How will I establish the diagnosis? So for diagnosis, we have invasive investigations and non-invasive investigations. We have invasive, which is nothing but liver biopsy, and this is considered as the gold standard. But of course, subjecting some obese individual just because you're suspecting that he may be having some fat in the liver and subject him to biopsy, patients may not accept, and in many cases it is uncalled for. So we must have some non-invasive tools for investigation. So what are the non-invasive tools we have? One simple tool is USG. Not very sensitive or specific for detection of fatty liver, but still it's a good initial screening tool. Most of the patients of fatty liver today get recognized as having fatty liver because of the radiologist report saying that ultrasound showed fatty liver. After that, further evaluation is required, and for that we have a scan called as fibroscan. So fibroscan analyzes the liver for two parameters. One, the degree of fat accumulation, and the degree of fibrosis, right? So we have two parameters in the fibroscan. The first parameter we will call it as liver stiffness. Let us write liver stiffness as the second parameter. First we will talk about the CAP score. CAP score helps us to assess the degree of fat accumulation. So normally it is less than 238. When it is more than 238 decibels per meter, it is suggestive of fatty liver. Higher it is, more is the quantity of fat in your liver. And the second thing is we will also measure the liver stiffness. Normally is less than 7 kilopascals. So when it is more than 7 kilopascals, it is suggestive of increased liver stiffness, which indicates that there is fibrosis. It is indicating that there is fibrosis. Okay. Now, yes, there is a role of LFT. What is the role of LFT here? So we now establish that there is fat involvement, right? With the biopsy or with the fibroscan, now we proved that there is fat in the liver, right? We have also looked at fibrosis, but what about inflammation, right? So whether liver is inflamed or not, that we can get to know from the LFT. So in the LFT, what am I interested in? Looking at increase in the ALT. AST is not very specific, right? AST can be elevated in rhabdomyolysis, hemolysis, and various other conditions. But ALT is liver specific marker. So if ALT is elevated, that means there is inflammation. So if ALT is more than 2 times upper limit of normal, it is suggestive of NASH. It is suggestive of steatohepatitis. It means now it is not just fatty liver, you have NASH, right? So in NASH, there will be elevated ALT. Okay. Fibrosis is identified by the stiffness score more than 7 kilopascals. Yeah, Rajendra, various sources will have the different numbers. Yeah, less. When I say more than 7, the next reading you get is 7.5. So it comes at the values of 0.5. So 7.5 plus, the 7 plus is fibrosis. Okay, so that's about the Diagnosis. Now that I have diagnosed, I know that if fatty liver progresses, it has the negative outcome. So I need to manage. Management. So how will I manage a case of NAFLD? Okay. From where all this problem started? All this problem started by excessive calorie intake and weight gain, right? Because body started using liver also as a storage organ for fat, which triggered hepatocellular injury and thus the inflammation, with that scarring, fibrosis, eventually cirrhosis, and from cirrhosis, hepatocellular carcinoma. The things can go on and on. So if I want to reset the cycle, what should I do? I should prompt the patient to lose weight. So the first and the most important thing and the single most effective treatment is weight loss, right? It is the weight loss. I forgot to mention one of the important risk factor which emerged over last few years is high fructose intake. See, there are so many simple sugars like you have sucrose, glucose, lactose. Higher amount of fructose intake is also linked to the risk of developing NAFLD. So in the West, there used to be this thing called as high fructose corn syrup, which used to be used for sweetening the dishes or pre-packed foods, but that has been linked to the risk of non-alcoholic fatty liver disease, right? So weight loss. So when patient loses, right, we would recommend them to lose more than 5 to 10% of body weight over 6 months. This itself sets the whole clock back. Significant amount of fat reduction in the liver also happens apart from fat reduction elsewhere. It can slow down or halt if there is a NASH stage already. If there is already inflammation, it can slow down or halt the progression of the inflammation, right? Apart from that, of course, because it is a lifestyle disorder only, it's not a liver disease. So other lifestyle modifications, if patient is very sedentary, taking too much of junk, he has to cut it down. Okay. Then the third thing, pharmacotherapy. Pharmacotherapy. So there are two drugs which have shown efficacy in clinical trials in reversing or slowing down the progression of non-alcoholic fatty liver disease, though not specifically approved by the US FDA for this indication, but because trials have shown and doctors do tend to use. So one of them is going to be vitamin E. Second one is pioglitazone. Pioglitazone. The relative efficacy of these drugs in trials is debatable, questionable. You can say that. And third, there are few small scale trials which are emerging and showing that the GLP-1 analogs like liraglutide or semaglutide may also be beneficial in slowing down or halting the progression of non-alcoholic fatty liver disease through stages. Again, how is it going to help? We know that GLP-1 analogs are very effective in causing weight loss. So they may be helping the patient achieve weight loss much efficiently. Thus, they may be helping the non-alcoholic fatty liver disease, right? So this is about our non-alcoholic fatty liver disease. We will move to the next question, which is on alcoholic hepatitis. Alcoholic hepatitis. So question goes like this. What is alcoholic hepatitis? Describe the clinical features, diagnosis and management. Okay. So what is alcoholic hepatitis and how is it different from alcoholic steatohepatitis? Right. We have a term called as alcoholic steatohepatitis, just like non-alcoholic steatohepatitis. We have alcoholic fatty liver disease, alcoholic steatohepatitis, alcoholic cirrhosis, right? So what is it? How is it different from alcoholic steatohepatitis? Alcoholic steatohepatitis or alcoholic fatty liver is a long-term complication of consumption of alcohol. If you continuously drink alcohol for several years, then it will trigger fat deposition in the liver, eventually inflammation, eventually fibrosis and cirrhosis. We know that if I just drink 1 month, I will not develop cirrhosis. I think many of you are a testimony to this, that you have not developed cirrhosis just by drinking for few days a month. But long-term alcoholism does. So this is a chronic complication of alcohol intake. Alcoholic hepatitis is a acute complication of alcohol intake. So alcoholic hepatitis is a acute hepatitis triggered by binge consumption of alcohol, and it is a life threatening condition. It's a life threatening condition. Unlike your alcoholic steatohepatitis, which is a very slowly progressive disease. I know a lot of patients will eventually present with cirrhosis and its complications and they may not make it, but it's a very slowly progressive disease. On the other hand, alcoholic hepatitis is very rapidly progressive disease. It's a life threatening condition. It is acute form of hepatitis. It is not a chronic condition. And another word that examiner is specifically looking for is word binge. Binge drinking increases the risk of alcoholic hepatitis, right? Now, what are the risk factors for someone developing alcoholic hepatitis? The first risk factor is female gender. If someone is female and then they drink large quantity of alcohol, they are at risk of developing alcoholic hepatitis. Second, binge drinking. What is binge drinking? Binge drinking refers to consumption of heavy quantity of alcohol in a very short span of time. Like weekend में पार्टी करना है दोस्तों के साथ मिलके, राइट? जितना हो सके 2 दिन में, जितना कोई दूसरा आदमी 6 महीने में 1 साल में पी रहा होगा 2 दिन में ही खत्म कर, दैट इज बिंज ड्रिंकिंग. कहने को तो कह सकते हैं ना कि हाँ साल भर तो नहीं पीता हूँ, कभी कभी एग्जाम रिजल्ट के बाद या एग्जाम खत्म होने के दिन उस दिन ही पीता हूँ, बट साल का सारा हिसाब 1 दिन में 2 दिन में कर लिया, दैट इज बिंज ड्रिंकिंग. कंजम्पशन ऑफ हेवी क्वांटिटी ऑफ अल्कोहल than your usual practice within a very short span of time, right? Binge drinking. Apart from that, previous history of alcoholic hepatitis. Okay, then presence of non-alcoholic fatty liver disease already or alcoholic fatty liver disease already also increase the risk of someone developing alcoholic hepatitis. What word examiner is specifically looking for? Again, it is the binge drinking. Now, how these patients present? These patients present with, they will present with acute onset rapidly progressive jaundice. Acute onset rapidly progressive jaundice. Remember, alcoholic hepatitis is a acute condition, so they present with acute onset rapidly progressive jaundice. Apart from that, because it is an acute hepatitis, they can have abdominal pain, they can have some degree of fever, they can have, as usual, whenever we have hepatitis, they can have nausea or vomiting. These are relatively non-specific symptoms. So if someone comes and says, sir, कंटिन्यूसली बहुत दिन abstinence में था, फिर suddenly I drank a lot of alcohol and after that I started developing jaundice, abdominal pain, fever and these symptoms. I've come to you, now help me, right? So from there you have to take it to the diagnosis. So how will I make the diagnosis of alcoholic hepatitis? So there's a 2019 American College of Gastroenterology criteria, which says the first thing that is required for the diagnosis of alcoholic hepatitis is rapidly progressing new onset or worsening pre-existing jaundice, which should happen within weeks, not like months. Second thing is, because we're talking about an acute condition, there should be increase in AST and ALT levels more than or equal to 1.5 times the upper limit of normal. So for majority of the jobs, upper limit of normal कितना है? Majority of the labs वो होगा around 40 to 48, 50 के आसपास होगा upper limit of normal for AST and ALT. So double that, sorry, 1.5 times that, right? It should be there. So without the elevation of AST, ALT, I can't call it as hepatitis. itis बोलना है तो at least ALT तो elevated होना चाहिए, right? Then there is a third thing. The third thing is the Third thing is AST by ALT ratio. AST by ALT ratio. This ratio has a name. It is also called as de-Ritis ratio. De-Ritis ratio. It should be more than 1.5, right? If you want, you can write ki most cases it is more than 3. Okay, very, very important point. And in the exam, examiner is specifically looking for this AST by ALT ratio. AST by ALT ratio. Why this is important? Because जो ALT है वो liver specific है, right? AST is not specific to liver. AST exists in your RBCs, right? It exists in cardiac myocytes. That's why even AST is a cardiac injury or MI marker. Okay, and it is also there in your skeletal muscles. So when you drink alcohol, does alcohol cause only damage to liver? No, it causes damage to RBCs. It causes damage to your muscles, right? In the long term, alcohol can also cause damage to heart, right? In fact, alcohol is one of the causes for dilated cardiomyopathy, right? So AST is getting released from RBCs, skeletal muscles, cardiac muscles, plus liver. ALT is getting released only from liver. So which one will have higher quantity in the blood? Of course, AST coming from all these sources, it will be higher. Second, ALT is a cytosolic enzyme, means it is expressed inside the cytoplasm, while AST is expressed in the mitochondria, and alcohol is a mitochondrial toxin. It causes mitochondrial injury. So AST will be much more profoundly released. So if I have AST by ALT ratio more than 3, it is highly suggestive of alcoholic hepatitis. It is a NEET PG MCQ point, right? So write that. And then fourth, to call it as alcoholic hepatitis, there should be evidence that patient was drinking, right? So there should be ongoing consumption of alcohol. The patient says that sir, 1 साल पहले छोड़ दिया है, now I have got jaundice, right? He may be having viral hepatitis या सालों भर पिया था पहले, तो now he might have developed the chronic alcoholic hepatitis, right? Alcoholic steatohepatitis. Can't be alcoholic hepatitis, which is an acute form, right? So there should be recent exposure to alcohol, right? Ongoing consumption of alcohol, और अगर कहता है कि most of the time story क्या होता है, patient will come and say sir छोड़ दिया है alcohol, बिल्कुल छोड़ दिया. कब से छोड़ दिया है सर? कल से छोड़ दिया. सिर्फ आज नहीं पिया है, कल से ही छोड़ दिया सर, अब आगे नहीं पीऊंगा. That is not abstinence, right? So we will say abstinence within last 60 days. Means if the patient says that 3 महीने पहले 4 महीने पहले छोड़ दिया है, तो it can't be alcoholic hepatitis today, right? After a sudden increase intake of alcohol, this presents. Okay, so that is about the diagnostic criteria. But what is the gold standard investigation for diagnosis? So whenever the criteria doesn't fit or you're in doubt, you have to go for the biopsy, right? The gold standard for biopsy, gold standard for diagnosis is biopsy. Not usually done for all patients, as long as these criteria are met, particularly the de-Ritis ratio, we make a diagnosis of alcoholic hepatitis. But जब भी doubt है, so we do the biopsy. And histopathology, what is it going to show? The first thing that histopathology is going to show is ballooning of hepatocytes. Ballooning of hepatocytes. Second thing which you're familiar from your path days, it will show Mallory hyaline bodies, right? Mallory hyaline bodies, or what you also call as Mallory Denk bodies. And third, inflammatory infiltration. Inflammatory infiltration. What examiner is specifically looking for? He is looking for the Mallory hyaline word. Okay. So once the histopath is done, we will talk about the management of alcoholic hepatitis. How do we manage? Okay. The drug of choice for patients with alcoholic hepatitis is corticosteroids. So first thing you have to mention is that it is a life-threatening condition because it can lead to acute liver failure. And once there is acute liver failure, patient will end up with hepatic encephalopathy and other complications, and we end up losing the patient. It has more than 50% mortality, right? It has more than 50% mortality. That means if I get 2 patients with alcoholic hepatitis and I don't treat well, I can send only maybe one patient home and one patient will end up in the morgue, right? So for such condition, aggressive treatment is required and the drug of choice is corticosteroids. Corticosteroids like prednisolone, like prednisolone or prednisone. But then steroids may not be helpful for all patients. May not be helpful for all patients. So what should I do in that case when steroids are not like either contraindicated or not helpful? What can I do? So alternative to prednisone. So we can consider using pentoxifylline and N-acetylcysteine. NAC stands for N-acetylcysteine. The recent studies suggest that N-acetylcysteine is somewhat useful and pentoxifylline is not very useful. Not very useful. So that's why many guidelines have revised and they mention that along with corticosteroids, adding N-acetylcysteine now becomes the drug of choice. If you want to write it, you can, or you can omit. You can just mention that corticosteroids are the drug of choice. Now, if you have time, if you can remember and if you can replicate, right, you can also write the approach. Whom to give steroids and whom should I manage conservative, right? So you can also write a little bit about the management protocol. So what is the management protocol? The management protocol is if it is a case of alcoholic hepatitis. If it is a case of alcoholic hepatitis, first thing I have to see is whether the alcoholic hepatitis is severe or non-severe. Now, what will be the parameter that I can use for deciding whether it is severe or not? Either I can use MELD score or Madri's discriminant function score. So if the MELD score is more than 21, or there is something called as Madri's discriminant function score. Madri's discriminant function score. Function score. If it is more than or equal to 32, this can be abbreviated as MDF. It is suggestive of severe hepatitis. In them, we have to consider prednisone or prednisolone plus N-acetylcysteine. And if the MELD is less than 21 or the Madri's discriminant function score is less than 32, right? So for such patients, we will primarily offer conservative treatment, means do a supportive treatment, ask them to abstain from alcohol and nothing more needs to be done. Okay. Now for those who do not respond to prednisolone, right? For non-responders, here also prednisolone, once we start, whether to continue for full course, the duration is 4 weeks or not will be decided by another scoring system called as Lee's model score, which will be done at 7 days post treatment. If they're responding, we will continue. If they're not responding, we will discontinue. No need to complicate your answer sheet with all the numbers. Mention this, it is more than enough, right? So for steroid non-responders, what can I offer? Only thing that we can offer for steroid non-responders is liver transplantation. Liver transplantation, right? So that's it about our alcoholic hepatitis. To summarize, what is it? It is an acute form of acute form of hepatitis, just like your viral hepatitis or drug-induced hepatitis, which is triggered by consumption of alcohol, usually in larger quantity in shorter span of time. So we'll call it as binge drinking. Relatively more common in females because probably female liver is not designed to handle higher quantity of alcohol, and usually occurs after an episode of binge drinking. All your MCQ based questions start with this only. After binge drinking it starts. Okay. Then in terms of clinical presentation, it's just like any other case of acute hepatitis, right? Sudden onset jaundice of just few days or few weeks, just like your viral hepatitis. But what takes me to the diagnosis is when I start investigating, when I look at the LFT, the LFT shows that AST by ALT ratio is usually more than 3. For diagnosis, I need it to be more than 1.5 with recent exposure to alcohol or ongoing alcohol consumption. In doubtful cases, we go for the biopsy. Okay. Management wise, steroids with N-acetylcysteine are considered as the drug of choice. Okay. Whether to give steroids or not will be decided based on the MELD score or the Madri's discriminant function score. If one of them is high, we give steroids for 4 weeks. If it is low, then we just try to manage conservatively the supportive care. N-acetylcysteine, we can give pentoxifylline. Doubtful benefit, we can give. But for those where we started steroids and they are not responding, in them, only choice we have is to push them for the liver transplantation. Okay, so that is about the alcoholic hepatitis. Okay. Pujari Sai Siva, we will be planning a residence course also shortly. You should get it in a couple of months or so, where we will be discussing, because these are all relatively superficial, primarily catering to the undergraduate students. For residents or PGs, we need to be based more on the guidelines. So we'll be coming out with one more for the residents. Okay. So we'll have one more question for today, which is on autoimmune hepatitis. Okay. So the next question is, describe the types and management of autoimmune hepatitis. Management of autoimmune hepatitis. So autoimmune hepatitis is another condition for hepatitis apart from your viral, right? So viral hepatitis is not the only cause for liver inflammation. So today we have learned about the non-alcoholic steatohepatitis, alcoholic steatohepatitis, and alcoholic hepatitis, and autoimmune hepatitis is one more condition, right? Okay, so I'm little running out of time, so we'll quickly cover it. So what is alcoholic autoimmune hepatitis? So autoimmune hepatitis is a disorder where there is autoimmune attack on the liver, just like your SLE, rheumatoid arthritis and all. Of course, it is an antibody mediated injury to the hepatocytes, and just like any other autoimmune disorders, it is more common in females than males, right? Talk about SLE, rheumatoid arthritis, everything is more common in females than males. So is autoimmune hepatitis. Okay. Age wise, there are two types of autoimmune hepatitis, type 1 and type 2. Type 2 tend to present in children. Why? We will understand in a bit. And the type 1 tend to present in middle-aged women, right? And whenever we think of autoimmune disorder in middle-aged women, what disease comes to our mind? A patient with malar rash and female, right? So type 1 is also called as leukoid hepatitis. Why is it called as leukoid hepatitis? Because these patients are often cases of SLA, right? SLA patients tend to develop type 1 autoimmune hepatitis. That's why all the factors match here, right? A middle-aged woman, female. Okay. In terms of ethnicity, the people in the Mediterranean population are having higher risk of developing type 2, which is children, and people in the North American and European descent are more likely to develop type 1. Okay. In what way they are different? Okay. So the type 2 is usually by an antibody known as anti-LKM1 antibody, and type 1, most common antibody that we get is ANA, right? That is the antibody that we get in SLA. So for all practical purpose, remember type 1 as the ANA or SLE, and type 2 is anti-liver kidney microsomal type 1 antibody. So in type 2, we are getting anti-LKM1 antibody. Then we have one more antibody here, which is called as anti-LC1 antibody, which stands for anti-liver cytosolic 1 antibody. Okay. And both of these are associated with risk of other autoimmune disorders. Like for example, type 2, there is increased risk of developing type 1 diabetes mellitus and pernicious. And type 1, I don't have to emphasize, you remember it. Type 1 is equal to SLE. That's what you have to remember. So type 1 patients are at higher risk of developing SLE, right? It is an autoimmune disorder. Now, if I have an autoimmune disorder, how will I establish the diagnosis? The diagnosis will be established primarily with the help of antibody testing. Okay. And gold standard, as usual, will be biopsy. So just like how we had the hepatic ballooning and malarial deposition in alcoholic hepatitis, Here also we'll have some biopsy findings. One of them is infiltration by the lymphocytes, which is nothing but inflammation. Then two things. There is formation of hepatocyte rosettes and interface hepatitis. These are the three words I want you to write. Don't worry, these will be added to the notes and given to you. And once the biopsy is considered, it is gold standard. Now, how do I make a diagnosis? Diagnosis, of course, based on the biopsy with the help of the antibody profile as well. Okay. We need to rule out viral hepatitis before I come to the diagnosis of the autoimmune hepatitis. Okay. Now, once I have diagnosed, how will I manage? Just like any other autoimmune disorders, our approach is going to be very similar. We treat them with steroids and immunosuppressants. Initially at higher doses to control the disease activity, after that maintenance doses, and those who continue to progress despite use of immunosuppressants, liver transplantation is the only solution that we can offer, right? So that completes our autoimmune hepatitis. I will put that into the notes and share with you. So that's all we had lined up today. There are a few more questions that you need to study from the Farre notes, which is available on the app, which is primary sclerosing cholangitis, Budd-Chiari syndrome, and the cirrhosis complications and management. Okay. So once that is done, you will be able to deal with all the major questions that they ask from the gastro and hepatocyte. Tomorrow we will discuss the infectious diseases. Right. So that's all I had lined up for today. I'll sign out for now. I'll see you tomorrow at the same time. We'll talk about some of the infectious diseases questions. See you guys. And if I have missed any of the queries, I'll be available on the Telegram. I'll take it from there. KK, yes, vitamin E is also helpful. Pioglitazone is also helpful. Not approved by FDA for this indication, but because studies have shown that it is useful, we continue to use. But if you ask me what is the most useful thing that helps to treat a patient with the NAFLD, it is the weight loss. Weight loss makes the remarkable difference in the fat load on the liver as well as the disease progression. Okay, so I'll be signing out now. I'll see you all.